the sixth webinar of the TeleECHO webinar series on pediatric and adolescent HIV treatment and care. This webinar, we are focusing on differentiated service delivery, and our webinar is titled Bringing DSD Home, Simplifying Models and Concepts for Children. As we apologize for our late start, but as we are joining the webinar, we would just like to start with a few housekeeping slides before we delve into the matter of the webinar. Next slide. For those of you who are joining, please note that we have interpretation, simultaneous interpretation for this webinar. There will be translators for English, Portuguese, and French. English because one of the presentations will be in Portuguese. And the function for interpretation is on your screen. It looks like a globe, as you can see, and all you need to do is click on there and choose the language of your choice. You have the option of listening to both the primary and the translated versions, or you can also mute one of the translations such that you can listen to the translation in a clear manner. Next. Next. Please note that on the webinar, we do have IT, back one slide, please. We do have colleagues supporting us. Back one slide. Back one slide, please. Back one slide, please. 2 slides now. Previous slide. Yes, we do have back one slide. Support from our IT team, the ECHO team. And if you need any support, please, can you please go back one slide? Use the chat function and type in ECHO IT to troubleshoot if you're having any problems. We are not going to be able to introduce ourselves, so kindly enter your name and where you're coming from into the chat box such that we know who we are speaking to. And just to note that this session is being recorded, and your attendance, therefore, to us means that you consent to being recorded, and we thank you for that. The presentation slides and the recording link will be shared by email for those who have registered after the session. Please give a couple of days before the session materials are available for you to download. Next. Next slide. For general comments during the webinar, you can use the chat box to all the panelists and the attendees. But if you have particular questions that you would like to direct to the speakers, please use the Q&A box, which you can see also at the bottom of your screen. We will be answering questions. The presenters will be answering questions in the Q&A function and not in the chat box. So please mind where you would like to ask your questions. In order for you to obtain a certificate of attendance, you will need to fill out a short survey, and we'll provide a link in the chat for you to access that survey, and the link will be available for the next 48 hours only. Next. Next. The objectives of the WHO ECHO webinar sessions we have been attending over the years is intended as a platform for information sharing and interactive discussion on progress and pending issues on scaling up pediatric and adolescent HIV services in priority countries. The overall goal is to flag challenges, but most importantly, to share solutions and trigger technical assistance by various stakeholders at global and regional levels. Next. Next. The ECHO webinar platform has been providing remote support and fostering south-to-south learning over the past couple of years, especially over the time when we had when we had challenges with as a result of COVID, and it has helped us to convene communities of practice on pediatric HIV and adolescent HIV. And the calls have included global updates on key issues. It has helped us to exchange our experiences between countries and learn from one another, and to update ourselves on clinical management and specific special considerations. Next. The participants extend from country technical working groups to this child survival working group, and includes also participants in the PATA network. So today's agenda is quite packed. We have, you can see it over here. We have, we'll be starting out with a presentation on the WHO recommendations, and then we'll be hearing from 3 country examples of models that are in practice. And we'll be then having at the end a panel discussion with our presenters and also participants from different communities and civil society to listen to their view on the demand side on differentiated service delivery and how it is perceived. At the end of the webinar, we'll be having a brief summary of the entire year, what we've been able to achieve over the year, and we'll have a peek and have an opportunity to contribute to what we will be listening to or what will be planned for the next year. So at this next. At this point, I would like to hand over to the chairs of this session. We have Nomthandazo Luhele. She is from WHO Eswatini, and we have Oluwafunke Ilesani, who is also another colleague from WHO Nigeria. I apologize, I did not introduce myself. I am Ivy Kasirye. I am a pediatric HIV consultant, and I support pediatric HIV activities.
Thank you, Ivy. Thank you.
Okay. Headquarters. I hand over now to Nomthandazo webinar. Over to you.
Thank you very much, Ivy, for that housekeeping updates. Good afternoon, good evening, colleagues. Welcome to today's webinar session. It is indeed a pleasure to have you join us from all over the world. I hope you'll find this session informative and enjoyable. I will not waste time. We move on with the agenda item. We are starting off with a brief overview of the 2021 WHO guidance on DSD for children, with a focus on the under 5 years, which is the subject for today. Ivy, who needs no introduction, will take us through this presentation together with another WHO colleague, Clarice. Just to introduce you to Clarice. Clarice is the DSD ART Technical Officer at the WHO Treatment and Care Unit in Geneva. Over to you, Ivy and Clarice. Thank you.
Thank you very much, Nomthandazo, and I will start straight away. Next slide. This is the overview of our presentation. We'll be starting off with the WHO recommendations, differentiated HIV testing, service delivery, and then differentiated service delivery treatment models for children. Next. I would like to begin, next please. Next. I would like to begin the discussion with a reflection on the barriers children and their families face, next slide please, in accessing care across the whole cascade. I will not go through the specific barriers, but there are barriers to testing and linkage to care, barriers to access access to treatment, viral suppression, adherence, and retention, and across there are also cross-cutting barriers that affect several points across the entire cascade. We are very familiar with these barriers, so I will not go into all of them. But differentially, later on, aims to overcome these barriers by providing tailored services to children and their families, as opposed to a one-size-fits-all. Next slide. It is therefore important that we emphasize that services should be differentiated across the cascade of care. And the WHO guidelines do recommend service delivery interventions that span across the continuum of care. You can see examples of some of these interventions indicated here. I will not go through all of them. These interventions have been described by the framework that you see here on the right, developed by UNICEF for improving HIV service delivery for infants, children, and adolescents. And these are interventions along a locate, link, treat, and retain components, in addition to cross-cutting system strengthening interventions. Again, I will not go through the interventions in detail, as these are all available within the guidelines, the WHO guidelines documents, but we are particularly familiar with several of these interventions out there in practice in many of our settings. But we need to look at these in terms of how do we tailor them for the specific client, a people-centered approach targeting the specific client. Next slide. I will just briefly turn our attention, very briefly, to differentiated testing service delivery approaches. WHO recommends differentiated HIV testing. Next slide. WHO recommends differentiated HIV testing service delivery approaches in a people-centered approach to address the needs of a variety of population groups, contexts, and epidemic settings. And this, of course, does include children. A differentiated approach for testing increases the opportunities and access for testing children. Differentiated approaches for testing should include mobilization, testing, and linkage strategies. When we look at mobilization, we can appreciate, next slide, we can appreciate that there are platforms on which mobilization can be done and strategies to create demand. For the mobilization platforms, these include peer-delivered participatory and community-led approaches, such as using peer educators, community groups, and faith-based programs, and several others that you may be aware of. And they also include digital tools based on HIV testing service approach, setting and context, including social media, text messages, mHealth, e-health, mass media, and other digital media, including short videos, which you're also familiar with. Whereas for the mobilization strategies for creating demand, these include targeted promotions, advertisements, messaging related to the attributes of specific HIV testing services that are available, such as unique settings or options or weekend hours. All those strategies can help to create demand. There are also educational programs, for example, drama, sports-based, faith-centered programs, which can be tailored to different populations to create demand. And also counseling strategies, for example, motivational messages that can be sent through our programs. Next slide. Next slide. HIV testing in children, what WHO recommends facility-based, either as a standalone service or integrated services in different settings, in high-burden settings for HIV infection. It is recommended that children of unknown HIV status who are admitted for inpatient care or attending malnutrition clinics should be routinely tested for HIV. And in settings of high burden, also children should be offered HIV testing in outpatient or immunization clinics. And in all settings, the biological children of a parent living with HIV or who may have died from HIV should be routinely offered HIV testing services, and if found to be either infected or at high risk of infection through breastfeeding, should be linked to services for treatment and prevention. WHO, next slide, also recommends community-based HIV testing services with linkage to prevention, treatment, and care services, in addition to routine facility-based testing. And this is recommended for all populations, particularly key populations in high burden settings, in low burden settings, and for key populations in low burden settings. Community testing includes home-based testing, mobile outreach testing in schools, places of worship, and many other settings that have been tried out by several implementing partners and programs. And finally, linkage to appropriate services following HIV diagnosis is a key component of effective comprehensive HIV testing services. Post-test counseling and other services that lead people to appropriate care should be implemented as part of explicit linkage strategy. And the core package for post-test services include clear and concise counseling messages, referral and offer of rapid ART initiation, and additional links to HIV prevention, care, support, and other relevant services. And many of you have either doing this or are familiar with programs that do this quite well. I will now hand over to my colleague Clarisse to take us through a more detailed presentation on differentiated service delivery for treatment and retention. Over to you, Clarisse.
Thank you so much, Ivy, and good afternoon to everyone. I'm very happy to be here. So I'm Clarisse Pinto, and I'll be covering DSD for art for children with a broader introduction in terms of the latest WHO recommendations for this area. Next, please. Next. Great. So Ivy already spoke about DSD being looking at adapting services to clients' needs, providing options that can reduce the burden of HIV services to clients and health systems, and that can be adapted to the client's changing needs. I think these adapt very well to the section now that we're going through in terms of focusing on DSD art and considering that children's changing needs need to be covered as well when we are talking about differentiated service delivery. Next. Click again. Great. So in 2021, WHO launched the HIV Consolidated Guidelines with updates and guidance in terms of service delivery and DSD for HIV treatment, but it also included many details in terms of HIV prevention, testing, and monitoring aspects. So in this slide, in the first box, you see we have the latest WHO HIV service delivery recommendations. And you can see where we're pointing at two key recommendations that are relevant for this discussion today are the frequency of clinical visits and ART refills between 3 to 6 monthly. Obviously, you have other interventions such as tracing support for engagement in care, psychosocial support for adolescents, back sharing of diagnostics and initiation of treatment outside of the health facility. And we consider that all these service delivery interventions are supportive of DSD. You can see there below that we have a box that points at the criteria for determining whether a person is established on ART. So in the 2021 review, WHO updated the criteria from when a person is ready for DSD ART from stable to established on ART. which is defined as people living with HIV, receiving antiretroviral therapy for at least 6 months, who have no current illnesses, which does not include well-controlled chronic health conditions, and with a good understanding of lifelong adherence, and also demonstrated evidence of treatment success, with at least one suppressed viral load within the past 6 months. So when it comes for children, you will see that there are specific details looking at whether viral load is not available. You can use CD4 count, higher than 200 millicells, and also looking at children from 3 to 5 years old with more of than 350, and also considering that you have to look at the physical aspects. And this recommendation for the criteria for established on ART should be applied for all populations. I highlighted that children because in many cases, the children are not being covered in terms of accessing DSD models. And we will discuss this aspect further on the presentation, but it's important to highlight some of the barriers for that to take place were mentioned by Avi in the beginning of her presentation. Next. So you might have seen these before. We consider that to implement DSD ART models, we need to consider the 4 DSD building blocks. By DSD, obviously, I'm talking about differentiated service delivery for HIV treatment. They focus on answering key questions when deciding which model to implement according to each population specific need. And here you're looking at deciding when to provide services, where to provide services, who will provide the services, and what type of service will be provided. A key note for children is that younger children from 2 to 5 years can enroll in three-month dispensing. Decentralization of ART refills is recommended. Task shifting of psychosocial support and ART refills to lay providers, peers, and caregivers is also recommended. And we should reinforce appropriate psychosocial support and adherence support integration when doing DSD for children. Obviously, the decision on which model to adopt should also be based on local assessment of needs, preferences, through community engagement approaches, as well as looking at factors in terms of clinical context and population. Next. So this is a summary of the DSD building blocks for children. This information is available not only in our consolidated guidelines, but other guidelines that were released since 2017, looking at specific needs for DSD for specific populations. I will not go into detail in terms of each of the areas mentioned here, but it's important to reflect that ART refills, clinical consultations, and psychosocial support should be thought of in terms of implementation separately and not all grouped at each of the clinic visits, for example. Next. So we mentioned before the frequency of ART refills, but DSD obviously is not only about frequency of ART refills or clinical visits. It's also about looking at differentiated models of delivering services. And we have come up with 4 categories of models that can be applied to each population with its specific needs. These models vary between group or individual models. It can be managed by clients or healthcare providers, and it might take place whether out or inside the health facility. So these models could be looking at family group models, like the example of Zimbabwe, the family refill model, where clients, and there was an adaptation of the existing community ART refill groups, and they were adapted into family models. They included children over 2 years old who were living with HIV and clinically established on ART. And they were able to provide 3-month dispensing to all group members, which included caretakers of children living with HIV. Next. So as Ivy mentioned before, there are a couple of areas we should consider to address while planning to implement these DSD models for children. They could be health system strengthening needs. They could be related to limited adoption of models due to concerns in terms of how to address the needs of these populations and concerns in terms of simplifying services for children. It could be absence of resources related to training of healthcare providers and many others. So these should be considered when planning and working on DSD for art. But there were also facilitators, and there are facilitators that we can take advantage of. One is the engagement of peers, caregivers, and community platforms to promote DSD, but also to create a community of practice that can support each other in the implementation of DSD art models. It could be strengthening not only, as I mentioned before, healthcare workers, but also strengthening parents and caregivers to give them all the tools they require to support their children, address all the needs related to progressive child disclosure, through counseling and support groups. The clinic flexible hours, and also what Ivy mentioned before, the friendly services that could be available for all the children that are coming in one specific day, the simplified formula and other specific models mentioned before. Next. And on a final note, we should highlight that reduced frequency of clinical visits and art refills for clients who are established on art should include children from 2 years old. DSD art improves client experience and health outcomes, so we should make a move into expanding the implementation for this specific group. Services should be designed to keep families together and therefore simplify access and reduce costs. And children should benefit from accessing DSD models and should not be excluded because of their age. I'm ending here with my presentation, and I would like to thank you all and hand over to the chair.
Thank you very much, Ivy and Clarice, for sharing with us the WHO guidance and showing us that the DSD can be actually implemented throughout the cascade from testing all the way to treatment. So allow me to take you through the next session, where we will now be learning from other countries' implementation experience. Once the WHO guidance is out, the desire is to see countries going through the guidance, seeing how they adapt it in their context. We want to upload the countries that have done so, and today we'll have 3 countries sharing with us their experiences. We will start off with Tanzania. So from Tanzania, they are implementing the Chitambu DSD model for pediatric ART optimization. We will start off the presentation with Dr. Theopitsa Masenga, who is the Senior Technical Advisor on Pediatrics at ECPAF, Tanzania. Over to you, Doctor.
Thank you so much, Nomfi. So can you go to the next slide? Yeah, so I will quickly take you through the differentiated service delivery model that engages a caregiver to optimize ART services. And before that, so I'm going to introduce our Elizabeth Glaser Pediatric AIDS Foundation, which was formed in 1988 as a non-profit organization dedicated to preventing and eliminating pediatric HIV infection and AIDS through research, advocacy, technical assistance, and prevention and treatment programs. And so the Elizabeth Glaser is renamed after Elizabeth Glaser herself, where she made commitments to make sure that she advocated for availability of pediatric formulation as well as the pediatric ARTs at that moment when children were dying without treatment. So we span around the globe, and we have more than 15 countries in Africa where all the projects and programs are committed to a comprehensive response to fighting HIV and AIDS at each stage of life, from infancy to adulthood. Next slide. Yeah, so a little bit of background in Tanzania. So Tanzania adopted and released the Service Delivery Models Guideline and operational manuals back in 2017. And from there on, the country programs adopted that guidelines and started implementation. So in our project, we established different service delivery models according to the national guideline, but also we had to innovate some of the models to be able to get desired results. So we looked into the data and saw that the ART optimization in children 0 to 9 years was very low. And back in 2019, viral load suppression was very low as well. So we wanted to innovate around the recommended to be able to speed up the ART optimization, but also to reach more children at a time when was really needed. So the project implemented a tailored differentiated service delivery model to address the challenges around pediatric ART optimization, and aiming at improving the quality of care, but also to improve the viral load coverage and suppression for the population of 0 to 9 years. So the model was renamed as Jitambue, whereby it engages the caregivers of children living with HIV, and also it involves the review of the care package that is provided, and it involves disclosure sessions, and therefore was given the name Jitambue, which means is understanding the HIV status and also understanding the care package required by children. So the main goal of this differentiated service delivery model was to review the care package for children, aiming to improve the caregiver support to their children in adhering to recommended treatment at home, also changing the ARV to optimal regimen and dosages, but as well as to adhere to guidelines in taking viral load on time. Next slide. Yeah, so the Jitambue model, initially it was started in a few facilities where it went through a cascade, as you can see on the slide. So we started with identifying high volume facilities to do the pilots. And then we oriented pediatric mentors and healthcare providers at that particular facility as a multidisciplinary team. And also we invited children and their caregivers to a specific clinic where the care package was reviewed, and also the empowerment sessions for the caregivers was provided. So during the specific or the special clinic, we had 3 main sessions. One is health education on HIV/AIDS topics to the caregivers. And 2, we do a one-on-one consultation with the caregiver and the child. And also we do a disclosure session, a practical session to the children, but as well as to show the parents or the caregivers on how to disclose when they are at home. And then we developed an assessment form to look at what services are provided and if they were provided on at optimal level as compared to the WHO standards, as well as comparing with the national guidelines. So what you are seeing on the right side of the slide is the assessment form, which was later adopted at the national level to review children who are suspected of treatment failure. Next slide. Yeah, so the different service delivery model was implemented in 3 phases. Phase 1 included a pilot, which was around August to December 2019, and involved 38 health facilities in 2 regions. And the aim of this was to create understanding of the current practices as baseline. And at that moment, we were aiming at changing from the non-nucleoside reverse transcriptase-based regimen to protease inhibitors-based regimen. Phase 2 was a scale up, which took place from January 2020 to September 2021. And we scaled up to cover 256 high volume facilities in 5 regions. And at that particular moment, we were targeting at transitioning from nucleoside reverse transcriptase inhibitors, meaning the nevirapine and efavirenz-based regimen, to lopinavir, ritonavir boosted tablets and liquid, or lopinavir, ritonavir granules from 2020 April. The third phase included integration into clinical visits, which started back in October 2021 until now. And these services were integrated in 433 health facilities in the 5 regions. And at this particular moment, we are changing now from lopinavir boosted ritonavir all formulations to pediatric dolutegravir 10 milligram based regimens. And now it has been integrated to take place matching with the 6-month month dispensing, which means we do the 360 evaluation after every 6 months. Next slide. Yes, so these are the baseline results, or the results for the pilot phase, whereby we saw more than a third of the children who were assessed were receiving wrong regimen, wrong dosage, and wrong frequency. And a quarter of them were not storing the medications in the original containers, so some in papers and some were just out the containers. And more than a quarter of them, they were crushing lopinavir, ritonavir tablets, which is contrary to the administration regulations. Next slide. So this slide shows the trend in ARV optimization, especially for the first line, whereby we observed that there was a rapid acceleration of transitioning from nevirapine or efavirenz-based regimen to lopinavir, boosted ritonavir, or dolutegravir-based regimens. And as I said before, we are observing that most of the children were receiving suboptimal regimens, and this exercise kind of accelerates the transitioning to the optimal regimen. And the optimal regimen was defined as receiving lopinavir boosted ritonavir if the weight was less than 20 kilos, and transitioning to dolutegravir-based regimen if the child was weighing 20 kilos and above. And therefore, by October to December 2020, none of the children were receiving nevirapine-based or efavirenz-based regimen because of the model that we are using to assess every child at the consultation. Next slide. Yes, so this slide shows the trend in viral load suppression for the population of 0 to 9 years, where before the Gitambue model, the project was experiencing very slow progress in viral load suppression before 2020. You can see on the Q4 of the 2019, we were still at 68% viral load suppression. And this viral load suppression was below 1,000 copies, was not even below 50 copies. So after introducing the model, we saw a significant increase from 68% to 76% in 0 to 4 years, and a significant increase from 79% to 79% in the 5 to 9 years. And by June 2021, the 5 to 9 years reached 91%. So this was a great milestone. And because also at this particular moment, a majority of the children 20 kilos and above had already transitioned to dolutegravir 50 milligram based regimen. But despite the intervention, we observed a slow progress also in 0 to 4 years in terms of viral suppression, despite the fact that they were receiving optimal regimen of lopinavir, ritonavir regimen. But this also, we thought it was contributed by the challenges that were faced around preparation and administration of the granules, and before that, administration of the tablets, which were quite difficult to swallow. Next slide. Yeah, so this slide shows the lessons that we learned through the implementation of the differentiated safe delivery model. So first lesson was that the drug administration remained a challenge and requires a continued effort to check knowledge and demonstration, because as we were checking knowledge of the parents, we thought
we felt like parents were facing a lot of challenges around preparation and administration. And through that, they were not able to navigate the processes to be able to get adequate information from the caregivers to show them, to demonstrate them because of the number at the facilities and the HRH issues. Also, the parents and the guardians, they lacked confidence to disclose to their children the HIV status. And so that was also part and parcel of the hurdles that they needed to get empowered at the facility level to be able to do the disclosure at their home. And another thing that we learned is that countries can adopt the model as a strategy to transition to new regimen, and also to assess the quality of care that is provided, and also to assess the caregiver knowledge on the pediatric HIV care to understand their needs and support their needs at home. So the way forward is that the differentiated service delivery model is now part and parcel of the case management strategy for identifying eligible clients or recipients of care for viral load testing and enhanced adherence counseling, especially for those with high viral load. And another thing that was good out of this differentiated service delivery model was that the assessment tool was adopted by the National AIDS Control Program to assess children who are suspected of treatment failure before genotypic antiretroviral resistant testing. Next slide. Yeah, so thank you so much, and back to you, Chair.
Thank you very much, Doc, and we appreciate the work that the Tanzania team has done in sharing the lesson. From the presentation, we could clearly appreciate the barrier that they had, the challenge at hand, and the innovation they came up with, and the lessons that they have learned through the process. And this is the purpose of this meeting, that we share experiences, especially on the how, because we all have challenges on wanting related to increasing viral load coverage, viral load suppression rates among our children. I will request that you make use of the question and answer session so that you get to know more about every presentation that will be made. We move on to the next presentation, where we will be getting the Kenya experience. We have Dr. Immaculate Mutisha, who will present on the family-centered differentiated model of care, the Papa and Mama care. So again, as they are presenting, please pay attention to the context, the innovation, and the lessons. And if there are questions, you put them in the QA. Over to you, Doc. Thanks.
Thank you so much. Good morning and good afternoon, everyone. I will be taking us through the family-centered differentiated model of care for Kenya. I'm presenting on behalf of Dr. Abut, who is not able to present. Next slide. So this is the presentation outline. Next slide. So just to start off is just to highlight that the HIV burden in Kenya, we have an HIV prevalence of about 4.3%. And the biggest burden is in about 5 high burden counties where the current prevalence ranges from 10% to 17%. We have an estimated population of 78,000 children living with HIV, against a population of 1.3 million adults living with HIV. And in terms of new infections among children, we have approximately 5,000 annually, but this has been varied over time, and we have seen a significant decline over time as we have implemented PMTCT strategies. Next slide. So overall, according to the 95-95 targets for 0 to 14 years, what is notable is that while we have at 74% ART coverage, our viral load suppression nationally is about 65%. That is population level, with a program viral load suppression of about 88%. Next slide. Next slide. So this is the adolescent cascade, just looking at, again, viral load, the entire cascade from case identification through viral load suppression. And again, what is notable is that due to the gap of case identification, our viral load suppression stands at 68% at population level coverage. Next slide. So in terms of our updated guidelines, we've updated the Kenya National Guidelines that are launched this year. We've adopted the 3-test algorithm for HIV testing, largely because our current prevalence lies less than 5%. We've scheduled to optimize all our children and adolescents. We have adopted the LDL cutoff of less than 50 copies as a country, and we've redefined our DSD eligibility for both pediatrics, adolescents, and adults. Next slide. So overall, in terms of our CAL HIV on first line, about 90% are on first line, while about 11% are on second line, with very few on third line, and which we are supporting through the intensified support, working very closely with the national program and third line TWG to support children who are failing second line treatment. Next. So I will go briefly over the PAMACARE model. Next slide. So PAMACARE stands for Papa and Mama Care, and this is a family-centered differentiated model of care for children living with HIV. And PAMA stands for Papa and Mama Care. We are able to pair children and their caregivers because close to 90% of our children living with HIV have caregivers. And we have a few who are unpaired, and these are children whose caregivers are HIV negative, either the adopted children, orphans, or children from children's homes. Next slide. So why PAMACARE? And we looked at program data, and what we noted is that up to 85% of children living with HIV have caregivers who are currently living with HIV. And what was notable is that up to 37% of children who are not virally suppressed, the left-hand side box, is that their caregivers are actually viremic. So for us to intervene and support children who are living with HIV, we cannot ignore the caregiver. We cannot work independently without focusing on the care of the caregiver, because that significantly determines the outcome of these children. Next slide. So basically then, how is PAMACARE, how does it fit into the DSD model? And PAMACARE is really anchored on the WHO DSC building blocks, from when to where, what, and who. And specifically, we focus on where we provide our ART refills, what we provide in terms of clinical consultation and psychosocial support for the program. Next slide. So who is in PAMACARE? So we are able to classify all our children living with HIV, determine how many are paired, how many have caregivers, and from that determine how many are stable and unstable. And for those that are stable, who are above 2 years, what we focus on is the viral load, the WHO, the weight for age Z-scores, as well as WHO stage. And then other characteristics that we also look at is adherence to appointment, stability of the caregiver, and the disclosure status of the child. Next slide. So then how do we describe our established children vis-a-vis our non-established children? So the established children, we provide a routine package that involves caregiver trainings as well as adherence support, ART monitoring, and management of other OIs. Whereas the intensified package really adds on to what we provide in the routine package, but we have additional services that we provide for these children who are not established, including enhanced adherence support, therapeutic feeding, mental health, and advanced HIV disease management over and above the routine care package. Next slide. So we have caregiver trainings, and we use the government developed tools for caregiver trainings, and we work with our caregivers to support adherence. We identify PAMACARE caregiver champions who can identify and connect with other caregivers and support them when it comes to matters disclosure, matters adherence. And we also provide child-centered activities at the facility to ensure that children connect with each other and they're able to receive the care. Next slide. So we provide differentiated services further for the unstable children, and what we are providing is video directly observed therapy. And this is a video support for adherence to ensure that caregivers, while at home, they can be able to take videos that are time-stamped, and we are able to follow whether the children are taking the medication, and we can review this information at facility level. And we are finding this intervention very efficient in helping us reduce the number of case manager visitations, which is a lot more expensive, but it's much cheaper to do the video directly observed therapy. Next slide. So this is how we organize the when in PharmaCare, or how to provide the services. For the established, we provide routine care with 3 to 5 monthly appointments, whereas for the non-established, this is based on the patient. We align all other services with the clinic visit, be it disclosure, be it nutrition, depending on whether the child is established or not established. We're able to ensure that there is no increased number of clinic visits that would otherwise be tied together to provide the service package. Next slide. So moving on to where PharmaCare is happening. So one is to highlight that we started off as a facility-based fast-track model for established patients and viremic clinics for the non-established patients. We are moving on to community activities, specifically focusing on case management, virtual adherence, and directly observed therapy. But looking into the future, we envision that stable PharmaCare child caregiver pairs will receive ART dispensing at the community and will be able to benefit from what the adult program is also receiving. Next slide. So looking at our PharmaCare scale up, and this is mainly in the counties which we support, up to FY21, we had up to 99% PharmaCare uptake for both stable and the unstable pairs. Next slide. So we have had a lot of improvement in terms of disclosure for both for the younger children, 10 to 12 years, as well as the 13 to 14 years. And this is largely because we are providing family-centered care that also provides very intentional disclosure support to the caregivers so that they are able to provide full disclosure for the children. Next slide. We are also leveraging on PharmaCare to use multi-month scripting for our children, and we have scaled up this significantly with most of our partners reporting over 70% MMD for our children. Next slide. This is the same, just talking about scale up of MMD. We did have an issue with unstable ARV commodities at some point, but that has since resolved, and we are envisioning that we'll see a significant improvement in overall overall MMD for this population. Next slide. So we have high rates of return to care for our program because we have reduced the clinic visits for both the caregiver and the child, and we are also utilizing the family-centered model, the caregiver and the child pairs, to really use SMS reminders for the caregivers for the sake of their own health and the health of that of their children. Next slide. In terms of overall outcomes, what is notable as of APR 2021, and why I present APR 2021 is because we had challenges with viral load testing. But basically what is notable is that we've been able to maintain very high viral load suppression for both the caregiver and the child. And again, also what is notable is that for the unstable pairs, both the caregiver and the child viral suppression is relatively much lower, but every time we get stable and unstable pair transition to stable, then we move them to the stable pair. So it's not surprising that overall the unstable pairs remain with a slightly much lower viral suppression overall. Next slide. This is overall in terms of improvement of viral suppression over time. We started off with 53% for the unstable children, and we've significantly been able to scale that up, and we envision to get better as the program continues to be scaled up. And the same is for caregivers as well. Next slide. So the other thing that is quite notable is that we have very high resuppression rates for PharmaCare child-centered model and the family-centered model, with up to resuppression rates of sometimes as high as 80 to 90% for the unstable pairs, and largely because we are providing directly observed therapy. Next slide. And lastly is just to highlight that the counties where we are implementing PharmaCare, we are seeing already population level improvement of viral load suppression across counties. We are working very closely with counties that are below 90% to ensure that we bring them up to speed in terms of overall scale up, but also the quality of care that they are providing for these children. Next slide. And this is a similar slide, just looking at the counties and showing where we are in terms of overall suppression. Next slide. So in terms of what does it take to implement PharmaCare is really to ensure that there's a policy that supports a family-centered model. We capacity build our teams and we monitor our data and provide a multidisciplinary approach that supports all the stakeholders. Next slide. Lastly, in conclusion, is just to say that we are able to really tie in PharmaCare into the WHO building blocks, ascertaining what service we are going to provide that ranges from ART reveal all the way to ART monitoring. The particular individuals who provide PharmaCare are clinicians, counselors, and the PharmaCare champions who are caregivers living with HIV, who support other caregivers. We do 3 to 4 monthly clinic appointments for both child and caregiver, and we tailor-make clinic appointments for the viremic children based on their need. And then we are mainly facility-based, and in future we are looking towards moving into the community to provide support for this population. Thank you.
Thank you very much, Dr. Immaculate. We appreciate your presentation. The colleagues on the line will help me appreciate you. We move on to hear more about the Mozambique experience. So this presentation will be in Portuguese. So those that cannot hear Portuguese, can they switch to English? And I will now allow Dr. Teresa Beatriz, the technical advisor for pediatric at the Ministry of Health in Mozambique, to present to the team the country family DSD at model for children as implemented in Mozambique. Over to you, Doc.
Thank you, Tandoso.
Thank you.
Boa tarde a todos. Meu nome é Beatriz
Good
Simeona
afternoon
e
to
eu vou fazer
everybody.
esta apresentação
I'm
em
going to do this
representação do Ministério
presentation.
da
It's
Saúde,
differential
sou
models
ponto
of
focal para
service
os cuidados e
to
tratamento
children
da criança
and
e
the
adolescente vivendo com
Mozambique
HIV,
experience.
e vou trazer a experiência de Moçambique no contexto da implementação dos
In the
modelos diferenciados de
context of
serviços
the
para
different
crianças.
differentiated models for children.
Próximo slide a seguir.
Next slide.
Este é o conteúdo da
That's the
apresentação, onde vamos
context
falar
of this
daquilo que são os
presentation. We're
objetivos, o perfil das
show
nossas
the
crianças,
objectives
a categorização dos modelos
models,
diferenciados que nós
profile of
apresentamos, que nós implementamos no país, os nossos desafios e as lições aprendidas durante este período.
challenges in the country
A seguir,
and also the lessons learned. After the recommendation of WHO, we define the objectives for the models inside the country, and all those objectives we're going to select those 6 with the frequency, reducing the frequency to the sites, to the also providing the integration to the user or to the family, and also to approximate the health service to the user, to the utilizer, and also providing the health service outside the normal time, and also then same parents, they can use after the working hours, they can take the children to the health installations, and also reducing the burden of work to the caregiver. And in a way that we can have reducing the work, the burden, and actually have more space between the different consultations, from 3 to 6 months, except for the children that really need to be seen more frequently. The profile of our children, it depends on their age and also in the period of their consultation. Less than 2 years, they've got a
a monthly consultation, and we also have to look that and they must go with the mother or the caregiver. There's every 3 months, a consultation every 3 months, and we can also adjust the medication to those 3 months, and after 6 months we can actually have the children can have every 3 months or every 6 months. But we must also check if to define if she should be integrated in another differential model. Then we classify our models to reduce the frequency of visitors. We also do. We actually dispense the medication for 3 months, or if they live near the health installation. But if they live quite far, then we actually give the medication for 6 months. And now there's providing the integration to the consultation to the client, to the family. We can have like a one-stop installation, or also a one-stop for the CNT medication, or like a familiar approach. We also have got models that we use to, we have some caregivers that they can take the service to the community, and we also have a model. We've got a polyvalent agent that it's in our health station that can also track the treatment of malaria. We use this caregiver that he can also dispense all the medication. He doesn't consult, but he can also distribute all the medication to our patients. And also we also dispense through some outbreak brigades. As there's certain emergency situations, we've got adjusted models for calamities, for the natural disasters, or floods or other situations, and also fights, internal flights, so that the population change from one district to the other. We also have other models for treatment for
E recentemente em outubro fizemos a atualização.
Recently we actually updated and also capacitation of all these caregivers. Less than 2 years. Now we have a family approach. The 2 to 9 years, there's a family approach. And also we've got the 10 and 19 years, we've got a youth-friendly service with a one-stop treatment in a ART service. Some of these models can be mixed we can have like approach family, and we can dispense every 3 months, but we can have a service of a treatment of one stop. This is a graphic it's MDS implementation in children from January 2021 to 2022. There's an increase of the coverage. Today we are 74. This data, we've got electronic system to report the data. The challenges that we have, the great challenge on these models encounter with the other the presentation of other countries. We're gonna see the viral suppression. We just the first challenge that we want to mention is to adjust the national policies in related to the global updates. We used to have the LPVR with less than 20 kilos. Now we change for the kids above 20 kilos. The kids, they had a transition, but we do integration of the multi-monthly dispensing or the medication for children with other comorbidities, chronics, like, for example, the epilepsy. And we must, with using the LPV Pediatric, we had another challenge because it comes in bottles of 90 tablets. We had situation that kids that at the end of the they had to go back to the consultation. They still had a lot of tablets left over, and what they wouldn't go to the consultation. Another challenge is also the integrating. I don't know what is the experience of other countries, but the integration of that monthly dispensing the tablets for kids with other comorbidities. And another challenge, it's the kids in school. Those kids with in school, normally we dispense, we give the medication 3 or 6 months. But then they can control their treatment. They need a caregiver. All this challenge we still have, and also needs a lot of monitoring, and then we can actually align. Then we cannot lose some kids due to the children or to the timelines. We have got electronic systems to register all the data, but we also have got manual systems that are also a good challenge. In March 2009, we need, we changed, mudamos para de LPVR para o DTG de DTG50, that for children are over 20 kilos. And now, in September 2022, we also all the the children, we have the children LPV, some in still LTV pediatric, but the problem it's to change to the bottle from 90 to the 30. We did this transition in March 22, but we still have a challenge to monitor. Then we didn't duplicate the medication. We also see the impact, the impact from the bottles of 90, but the children release. And they still stay true.
Associated to our community, so we have to do a work close by, and although they have still had medication, they should come back to the clinic. Now, with the introduction of the bottles of 30, it has improved, and I think we will have more information in the next quarter, especially in this abandonment and the loss of interest. In terms of lessons learned, we had to do a lot of work with the community, with the parents, and it is important to keep in contact with the parents, because it is a challenge to them, and the parents and the caregivers, they have other work, they have their farms, and so there's always a second caregiver. So not all of them have this, and we have a child that would follow the mother pregnant and exposed. So now we want these mothers mentoring that will help and assist. And from the 2 years, they will be followed better for the situations of emergency and mobility. We also put the booklet which registers the patients and their movement, and we keep it updated so that we can follow and can monitor the viral situation and the retention. And this is a challenge to us, and it is something that we are doing today in our approaches, and also to the counseling, and because they will have to be involved. This was all I wanted to present for the experience of Mozambique and our services. Thank you.
Thank you, Dr. Beatrice, for sharing with us the Mozambique experience, your guidelines, your tools, and the outcomes that you have achieved. So we've come to an end of this second part of the session where we were just sharing country experiences. Now it's a time for the first poll. I'll request that it is shared. So we've had the 3 countries present to us their models. It's time to reflect and look at where we are, the countries we are at, or the countries we are working in. Which of these models do you think could be implemented in your country? We've gone through the Tanzania one. You can just answer the poll. Please do, so that we see which ones are comparable to where you are. And it is, as the earlier presenters said, like Clarice mentioned that, and Ivy mentioned that DSD is not only about multi-month scripting, and I'm sure we could appreciate how the different countries have targeted intervention for the different challenges they are facing. So look at your country need or your context, which one of these models would be applicable in your settings, or you could implement. If there's none of the above, please write why. Please respond to the poll, because we will not move until we've heard your feedback on this. I hope we still remember the models. The Tanzania model was the one where they were doing pediatric optimization from NNRTIs to PIs with the interest of improving viral load coverage and suppression. Then the family-centered model that was shared in Kenya with innovations for patients that were stable and unstable. Big experience, which also showed us how they were even giving treatment outside facility, just some of the things I picked. I'm not sure how far we are with the poll. Is it working? Okay. Okay, in the interest of time, I think it's now time for me to hand over to my colleague, Dr. Oluwafunke, who will take us to the next session. Thank you very much. Oh, the poll results are here. So thank you for responding. And you could see that most of us think that the PAMA model, they can take, but also I think for the different context we're in, these models can be considered. And I can see that our problems are similar, or even our contexts are similar, because I'm seeing only a few persons said none of the models were applicable to their setting. So I will hand over to Dr. Olu to take us through the next session. Please continue participating as you have. Let's share experiences. Thank you.
Thank you, Notem. Good morning, good afternoon, and good evening to all participants of this ECHO session. I'll be taking it from here, and basically what we'll be having this session is to have a panel discussion of bringing DSD home. We don't have much time because we really need to finish this at the hour. Hence, I would like to crave our indulgence to stay with us, as well as ensure that the panelists also try to give us the information as quick as possible. On the panel, I have all the presenters that have presented to us today, and I have additional 3 people who will be presenting, who are representing the community or the civil society. They will be sharing their experience. I have with me Je Mbaruku from Mama and Papa Bears in Tanzania. I also have with me Anna Sango and Selma Iyambo from GMP Plus, who will be reflecting on the work that they do, as well as their organization's initiative, that is ending pediatrics aid in children. So let me run right away to ask the questions from Anna and Selma. Do I have my panelists in the room? Okay, good. Can I go on? Okay, so let me just go ahead and ask Anna and Selma the first question. We all know civil society and activism plays a key role in shifting the attention of HIV programs to person-centered approach, focusing on the needs of patients that are receiving the care. So Anna and Selma, could you share your experience as activists and give some details on the roles you play in improving access to DSD for young children. Over to you, please.
Thank you so much, Doctor. So I will introduce myself again. My name is Anna, and I work for GNP Plus, and my portfolio includes pediatric HIV advocacy, where we are working with different stakeholders and civil society partners to support communities in terms of raising a voice on pediatric HIV advocacy, and also identifying some of the important ways in which we can involve communities so that they can speak up for children. And my work also entails coordinating the Mama and Papa Bears. My apologies, Gia couldn't join us today to also speak on the Tanzania Mama and Papa Bears. But I'm sure Selma and myself will be here. So as I was saying, my job is to coordinate the Mama and Papa Bears. So this is a group that is set up through the end Pediatric AIDS in Children initiative that we're working on as GNP Plus, supported by AIDS funds. So the idea of the Mama and Papa Bear groups is to support young parents and caregivers in terms of navigating as well as being able to access the necessary services that they require when it comes to their children, and also children that they are caring for, which may be infected and affected by HIV. So we have 7 groups set up in 7 countries, and we're hoping to expand. And most of our groups are composite of young fathers and young mothers. So mainly they come around to discuss some of the issues or challenges they may be facing in terms of service provision or accessing services, and also discuss in terms of engaging in different spaces at country level to promote pediatric advocacy. So this could be engaging in PEPFAR COP processes. This could also include engaging in Global Fund processes through the CCM, and this also includes engaging within different technical working groups that are targeted and looking at issues to do with pediatric HIV. So we're super excited. And also speaking up in terms of these issues, as we know that we experience challenges at different levels, and depending on probably age and also context and also environment. So it's also good to just understand some of those challenges and some of those issues and come together to try and address those. So I think in a nutshell, that is more around the work that I do and the support that I give to young mothers and fathers. Thank you.
Thank you, Hannah, for sharing that with us. I like the fact that you are not only staying at the implementation level in the sense that the children or the parents, you're actually taking it up to the policymakers, the donors, CCM, PEPFAR, and all that. Selma, how have you actually, what is your experience as an activist in improving access to DSD for children?
Good afternoon, good evening, and good morning. As introduced, I'm Samuel Iyambo, and I am the Hair Voice Fund Ambassador to Namibia. And in terms of improving access to DSD for both children and in the context of adolescents, this is what we do. Seeing that I am the Hair Voice Fund Ambassador to Namibia, we work with various organizations within Namibia with the assistance of Hair Voice Fund under the global network of young people living with HIV. And those organizations actually go, or they serve as the bridge between the community and the government, saying that government is not able to reach everywhere, and there are specific communities that do not have healthcare facilities, and there are communities whereby they are deep within the informal settlements and people are not well educated or they're illiterate, making it hard for them to actually what is this, to actually assess the children that are living with HIV. Another thing is we mostly work with adolescent girls and young women, and seeing that most of them are young mothers, and we come in through the community outreach approach, because we also had a question within, what is this, within the question and answer, whereby they asked, do we also do community outreach? Yes, we go with the community outreaches deep within the informal settlements, whereby we do give this information, whereby we actually give support to the caregivers, because as mentioned before, there is no way we can help the children without the what is supporting the caregivers. So we also extend a helping hand to the mothers in order for them to be able to support their children. We give them the necessary information, and at times we also go in to say we are deep within this informal community, whereby we offer testing to children and parents. We also go within the informal settlements with what is this, to make sure that the pickup is also way much easier, because as you are far away from the health facilities, you often do not get refills on time because people are so further, and you also have costs that are involved. So we kind of bridge this gap by bringing the service closer to the people. Another thing that we also then look at is the fact that we have different needs, and as we go within the informal settlements, we get to realize that nutrition, and we cannot just emphasize in terms of the medication while there is no necessary nutrition. Hence, now we go in with also packages that also then assist these young mothers to actually get the necessary nutrition in terms of the food. We also can give out this dignity kits, making it or allowing them to be met halfway. And another way in which we also then actually diversify this is we work with the different health facilities, whereby should there be a need and we see that the child is actually needs more nutrition, this is whereby we are able to give the necessary food that we are able to give at that specific health facility, to ensure that it's just not the medication, but then you also come in terms of nutrition. Another thing is a psychological support for the healthcare providers, because how do you expect someone to give a helping hand to the children if they are not in the right state of mind and they need emotional support? And another thing, apart from the emotional support, is the fact that the caregivers they do not have the necessary information, or the illiterate. So the health caregivers, or we as with the organizations that work with young people, actually get to go there and be or act as care providers as they come within the time frame that the people are supposed to get the refills, to ensure that these young people and the children are not left out, but still we are working with them and ensuring that they get the necessary services with the children. Thank you.
Thank you for that. Thank you for sharing your experience. Jia, it's your turn now. Could you please share some experience of families with very young children that are receiving differentiated service delivery? What are the challenges, if any, that the challenges that families with young children face in accessing DSD services? Also, what would be your advice to programs who would like to provide DSD services for young children? The first is, what are the challenges based on your experience? And then what are the advice that you would actually give to ensure that these challenges are actually overcome? Over to you.
So, Doc, my apologies again. Gia was unable to attend, but I will share a few insights from her talking points. So initially, some of the challenges that they've been facing is issues to do with children that may be belonging to key populations. So sometimes the parents and the caregivers have a lot of challenges accessing the services because they are facing double stigma. So that then also transcends into the way they then access care and services. So you'd find that in most facilities and most service provision does not entirely accommodate, or rather kind of provide that support and infrastructure. So those are some of the biggest challenges that have been faced. And I think as a recommendation, it would be important to be very clear around identifying key groups such as these, and then being able within our service provision guidelines to ensure that we make that provision on how best do we support parents and caregivers who identify as key populations, as well as ensure that their children are getting the enough support that they need. And I feel like that's where differentiated service delivery models really have a big role to play in actually making sure that services are coming to the people and they are being brought to the people in a safe and dignified manner. So that's one recommendation I would give to programmers, because it is also important. And I think like Selma mentioned, to really be able to access services when you're also in a good state of mind. So that's one thing that's really, really important. And I think it's also good to ensure that services are integrated. We are not only looking at a person as someone who needs to just access their bottle of pills, but we also need to look beyond their mental state. We need to look at nutritional issues. We need to look at also the environmental and contextual issues that affect people. Like, for example, we're coming from a time where COVID was really rampant in a lot of countries, and a lot of people in terms of accessing services were facing a lot of challenges. And we needed to go the extra mile as service providers to ensure that we're really reaching out to people and ensuring that they are safe to access the services, and they're also doing it in a dignified manner. I think I'll just end there. Over back to you, Doc.
Thank you so much for that. Thank you for that. The way you addressed, you covered a lot. I hear double stigma as one of the challenges. I know because of time, we could not talk about all the other challenges. So please, could you use the Q&A room to actually state some of the challenges that you think also, the fact that you were able to talk about, on to Dr. Teopista from ECPAF is doing in providing DSD services for children. Would you consider, what advice would you give on the steps that programs need to take to be able to adequately address the needs of children? When it comes to DSD, what advice would you give for programmers to take on the necessary steps to address the needs of children? And also, would you consider it a model that should be implemented at a small or large scale? That is, based on the experience you've shared, would you consider it a model that should be implemented at a small or large scale? If large scale, what do you think should be the key for scaling up this model? Over to you, Dr. Teopista.
Thank you, Doctor. So to answer the first question around for the programs, if they want to adopt one, I will say is key to establish a facility multidisciplinary teams that will implement the activities and also support the special clinic where they need to have a team that will be empowering the caregivers, and you need another team that will be providing support the disclosure services with the children, and this is age disaggregated, and also support the ECD services at the same time. So you really need to have a multidisciplinary team at the facility level. 2 is to impact adequate knowledge and skills to service providers at that particular facility to be able to do a 360 round of review for the children and the family at the same time, and provide adequate information and counseling for the areas that like impeding the quality of care at facility or at home. And 3, you need to develop a very simple and clear guidance to healthcare providers on how to develop or to conduct the special clinics, to be able to do it with fidelity over time and at different levels, so that the level of knowledge that the parents or the caregivers are receiving is the same as the knowledge that the service providers are having, to be able to improve the quality of services. And 4th is that during the clinical consultation, it is mandatory to check the knowledge of the caregivers to make sure that they came in with all the medications that the child is receiving and so forth, so that you'll be able to advise if there are drug interactions, if the storage is not adequate, if they are mixing the dosages and the frequency, everything. So that is something that I will say it is mandatory for adopting the model. And two, if is to scale up, I will say you will need to scale up first at small size to be able to contextualize into the routine or onto the country specific customs. And then two is to scale up in large scale, because this is a part and parcel of improving the quality of care. So yeah, those are the two things that I will say in terms of scaling up. We start small and then you go to large scale to be able to accommodate the flexibilities and the areas that where you need to really modify to meet your country context. Thank you, and back to you.
Thank you so much for that. Let me run quick to my colleagues from the Ministry of Health Kenya. And the question is, what are your experiences providing DSD services to children younger than 5 years at various points in the continuum of care? Not the continuum of care. Then what would you consider? Would you consider it a model that should be implemented at a large or small scale? If large scale, what do you think would be key for scaling up this model? Over to you, either Dr. Grace or Dr. Lazarus. Over to you, please. Hello? Hello?
I think they're not, they have fallen from the call.
Oh, okay. So then I would just go straight to you, Clarice. And basically, the question for you, Clarice, it's how does, we've seen colleagues now, we've seen from the Ministry of Health Kenya, we've seen from Tanzania, we've seen advocates from Papa and Mama Bear and all the others. We've seen colleagues from Mozambique share their experiences with us. So how does country experiences of implementing WHO recommendations and normative guidance inform WHO processes? Over to you, Clarice.
Great, this is a great question. Thank you so much, Funke. This is quite important for WHO to be able to build on this evidence that is found in the field so that we can use this to update our guidance and the policies that we recommend countries to implement. So there's nothing that WHO publishes that is not coming from country experience and research. Especially in this case, looking at operational science, implementation science that can inform us on the considerations for implementations of all the recommendations that we are launching each year. So specifically looking at the examples from today, this is quite important because it gives us the details in terms of how countries are actually implementing the guidance, which types of adaptations they have done to be able to make sure that they cover specific needs for the different populations within a specific context. So this is quite important for WHO to continue to see these implementation information and articles, publications from countries, so that in time we can adapt our guidance according to the experiences from the field, from the countries that are common and that are a learning point for other countries who are struggling to implement. Part of the WHO work is also using these platforms for dissemination of the guidance and dissemination of information in terms of implementation. So we are using a different way of disseminating information, but also making use of what we have available from countries.
Thank you so much for that, Clarice. Now, I think we've come to the end of our panel discussions. And in summary, we have, in addition to the presentation that we had earlier on, we have activists from Papa and Mama Bear. We have Anna and Selma who have shared with us how they were actually able to ginger colleagues at the national level, as well as at the even the people receiving the care themselves, to actually be able to understand what DSD is about, the need for DSD, especially for children, and also ensuring that children are able to access these services. We've also heard from Clarice in HQ, WHO HQ, who has shared with us that what we are doing at the country level is not just we are doing it for doing sake. She has actually explained to us that all the things we are doing are all coming together and used in informing WHO processes as well as WHO recommendations and guidelines. On this note, I think we would actually give each and every one of us a round of applause because our work is not just being done in the corner, but it's actually translating to global policies that other countries that have not yet implemented DSD are actually being guided to take on board. Thank you very much for coming with me on this panel discussion. And on this note, I'd like to hand over to Ivy for her to close the meeting. Thank you, over and out.
Thank you very much, Funke. I hope I'm audible.
Yes, you are.
Okay, thank you very much for an excellent panel discussion and excellent moderation. I would like to encourage participants not to leave because we have a final part of this session in which we really need your input. This is where you come in very important as we plan for 2023 and and we shape the topics that we would like to hear about in 2023. Kindly stay on to participate in that. So as a brief wrap up, next slide. I will not spend a lot of time. We have had on this because the two session chairs have summarized this very well. We had an overview from the WHO guidelines for DSD, highlighting the need to provide differentiated services across the cascade of care. We heard from 3 DSD models, the Jitambue DSD model for pediatric ART optimization from Tanzania. And what struck me is there was still a gap seen with children 0 to 4 years who still had low viral load suppressions, and this was clearly associated with the challenges with the lopinavir administration. It would be nice to follow up and see what happens now that they're receiving pediatric DTG. We had a presentation of the PAMA model of care from Kenya, and we had a presentation from the Mozambique family DSD ART model. And we had a very interesting panel discussion with considerations from civil society on the demand side, learning a bit more about what the needs are and where the gaps are. And we had practical tips from presenters on establishing and scaling up DSD models for that they shared during their presentations. We do apologize. I think there have been a few glitches here and there with the translations and of course the late start. We apologize for that, and we hope that in our subsequent webinars we will minimize such glitches as much as is humanly possible. These things happen with technology. So next slide. I will now move on to summarizing what was 2022 for us with WHO webinar sessions. We had 6 webinars in the year. We held them every 2 months, starting in February and ending with this last one in December. So we had one addressing priority needs of adolescents and young mothers living with HIV. We had one in April dealing with peer-driven models of care. The one in June was addressing HIV-TB co-infection. The one in September was addressing HIV drug resistance and ARV sequencing. In October, we had a very interesting webinar on adolescent HIV and mental health integration, and today's webinar was on DSD models. Next slide. So when we review the year and see how we performed next year, Next slide. We had an increase in the number of countries that were attending, that registered for these webinars.
Participaram neste webinar.
Last year to 82 countries this year. We had a slight decrease of unique participants from 1,780 to 1,419 unique participants. Next slide. It will be important for us to understand where the needs are and where the gaps are. We have participants from all over the globe. You can see where the participants are coming from, the majority in the Afro region, but we can see participants from across the whole world. Next slide. This was the level of participation across the different webinars. Attendance in 2022 increased from 2021, and the attendance was highest in September on the webinar addressing HIV drug resistance and ARV sequencing. Clearly, this was a gap, and there was a lot of interest in that particular webinar. This was a case-based webinar, and it was quite interesting. Next slide. The attendance per session has remained as it was last year, with the majority attending at least one session and fewer as we go down attending multiple sessions. So we'd like to see in the coming years more attendance across more than one session through the year. Next slide. The majority of the participants are medical practitioners, including medical doctors, public health officers, and nurses, but other professional categories are also represented, including administrators, researchers, community health workers, mental health practitioners, all depending on the nature of the webinar. So we are happy to see a broad professional representation at these webinars. Next slide. The majority of participants work in the NGO and the public sector, and as you can see, fewer and fewer in the private sector. But we are actually reaching the target that we are seeking to reach in the public sector and also in the NGO sector, which are majorly responsible for providing HIV services. Next. The majority are in the public sector, as I already mentioned, and the non-profit sector, with very few participants in the private sector. Would like to see the private sector also increase, as there are a number of our patients who are being managed in the private sector. Next slide. Majority of the participants work at national level. And this is important, with 42% working at subnational level. Next slide. We do see that for majority of the participants who responded to the polls, that the sessions have been useful for them, from extremely relevant to very relevant, and we are happy to see that. And this makes the next part of this webinar so much more important, that you choose the topics that you would like to see next year. Next slide. We find that the participants found that the webinars have a balanced learning experience, not too much lecture, and would like to maintain this kind of learning, and therefore even in the poll would like to ask you what more you would like to see in the coming sessions and the way in which you'd like to see them carried out. Next slide. We do see quite a bit of learning that is taking place, and we are happy about that. We are seeing the graph moving from before the session to after the session knowledge, being more knowledgeable following the session. Next. And yes, many of you responded that you will be using the information that you obtain from these sessions in your workspaces, which is really the ultimate goal of the webinars. Next. So in summary, we are reaching the target that we intended. We are reaching a large number of participants from diverse settings across the globe. And of course, therefore also different types of epidemics. And then the webinar topics were identified by participants in 2021 and would like to carry out the same exercise this year. Majority found the webinars informative and useful for their work. And we are planning, finally, we are planning to continue the sessions every 2 months in 2023. So the frequency of the webinars will remain the same next year. Next slide. So the first call I would like to carry out is question number 2, is to what would you like to see more of in the coming webinars? Would you like to see more case studies, best practices presented, sharing of tools, scientific updates, WHO guideline topics, panel discussions, or interview format? Which is the mode that you would like to see more of in the coming year? Kindly respond to the poll. I'll give you a minute to respond to the poll. What would you like us to do more of in the webinars? Okay. Do we have some answers for this poll question? Kindly answer, let us know how we should do the sessions next year. What do you want to see more of? Okay, great. The majority, the response is on best practices, which is really what we aim to do with our self-learning, learning from each other. Case studies, yes. Guideline topics. Okay. Thank you very much for these responses. We will try our level best to respond accordingly. And the final poll question. As we shape the agenda, would like to understand what topics you're interested in. We have a list here of 10 topics, possible topics, and would like you, it's a multiple choice, so pick up to 6 answers such that we can select the top topics to carry on in the next year, 2023. So what topics would you like to learn more about during the year 2023? Please select up to 6 answers, and it is a multiple choice. Pediatric DTG updates, disclosure of HIV status to children, management of advanced HIV disease, infant diagnosis, including evolving scenarios and new issues, adherence, retention, and care, quality health services and global standards of quality, community engagement and empowerment, service decentralization and integration for children and adolescents, services for pregnant and adolescent mothers, and management of HIV/TB co-infection. Okay. I am seeing messages coming in from the participants that they cannot see the questions. Anyone from IT to advise? Because we're looking at them on our screens.
So I believe they are facing some bandwidth issues at their end.
For the participants, maybe the IT team, do we have a representation of respondees for the poll 3? If not, we may have to send the poll on email. Okay, great. Thank you very much for these responses. We will look at it like all of the topics are equally represented. But we will have a look at these topics and use this information, take them into consideration while we plan the webinars for next year. Thank you very much for this input. We will look at it in great detail and come up with an interesting agenda for 2023. Next. So once again, I will just run through some of the expectations coming next. This has been a call from our side. Every single webinar is to remember how to provide services for children by placing the family at the center and ensuring that every contact they have with the health service is as well-rounded as possible, and the services that they receive are as the services that they need, the diverse services that they need. Next slide. And just to remind you about the AIDS-free toolkit, it is at your disposal. Please use this toolkit. It has a lot of information that you will need, including, next slide, the optimal formulary for antiretroviral drugs for children with implementation considerations, which supports countries that are optimizing treatment for children and their national programs. This is an important document. Next slide. The ARV dosing dashboard, which is a very useful tool, even for the frontline health worker to quickly and appropriately dose pediatric ARVs for the children they see in their clinics. Next slide. We have another tool, which is the comprehensive package of care for infants and young children exposed to HIV, which was released in 2022, which looks at the HIV exposed, the infants and children exposed to HIV and the comprehensive manner in which we approach service delivery to this population. Next slide. And one of the updates we have from our PATA colleagues who are partners in delivering these webinars is that the PATA Summit recordings and presentations are available to be viewed on the PATA Hub, and that is the link. You will need to register on the Hub in order to access these materials. And in terms of the materials from this ECHO webinar, once again, like we announced in the beginning, you will have access to the presentations and the recordings. They will, for all of you who registered for the webinar, and they will arrive, you will receive an email in a couple of days. It is not immediate. In a couple of days, you will receive an email with a link to the materials. So please be patient and wait for the materials to arrive on your email addresses. Next. Once again, I would like to thank all our partners who have been involved in the preparation of this webinar, and to the speakers, the moderators, to the session chairs, all of you who have accepted throughout the year to participate in these TeleECHO webinars. It has been a very interesting ride. Thank you very much for whatever's gone wrong in this and previous webinars. We apologize and hope to do better in the coming sessions. For any questions that have gone unanswered, unfortunately, the Kenya presenters seem to have had a connection problem and they dropped off the session, so we're unable to answer the questions. We apologize for that, and we hope to see to address all of these in the coming webinars. So thank you very much for attending. This is the last webinar for the year. We would like to wish you a very Merry Christmas and a Happy New Year. And we have a little video for you, a celebratory video to usher us out of the 2022 and into 2023. And we wish you all the best. Go ahead. Bye, everybody. I'll switch on my video for this.
Am I just an equation? Just the sum of my parts. Whenever you go near me, you don't hear my heart, and it beats. A million constellations, a dream that still unfolds, and it's hard to wake up, and it's hard to be bold when you leave me on my heart. Instead of running on the numbers now, why don't you come and check my name first song? Or maybe let me in the eyes, mama. Instead of writing your papers from far away, 'cause I'm so tired of these signals on. They make no sense to my life for sure. I'll take my powers to the masses broad, and you just sit there and roll your dice from far away, you're 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 far away. You should get to know me better. Not surface things that show you well. And I know what fights my battles better than I have done and still do now. I got away many lifetimes on these young shoulders, but I don't wanna cry this alone. No, I don't wanna be so strong. See, I know I'm resilient, 'cause I've been swallowed in survival. But together we're magnificent. Together super.
Look up, Hona. Divide the skies into 88, rising like the new design. Come and watch me demonstrate. Kubata needs a shades, kuflex sema gates. Dishmanya mucha denga, dashika mucha tenda. Chigokam, Hona, Lazarova Pona, my superpower keta. Habasati Vambo Ona, Habasati Vambo Ona, Habasati Vambo Ona. Rumeri Mwe Hari Kumbe Choose. 1+1 in every target. Chigero Chena, Chandire Mera. I'm sitting between my body female. Sandy Shore. My name is written in the stars. Fire to the galaxies, from edge down to Mars. Ikaro Siva, Urunai Piwa. Since day one, I've been in
You should get to know me better. Not surface things that show you well. And I know what fights my battles better than I have done and still do now.